But I still use anthracycline-based regimens for our highest risk patient population.
You did highlight the adverse effect profile and the toxicity, and I think we were really quite reassured to see no grade 5 events or deaths related to ILD.
Yes.
Could you tell us a little bit about the toxicity that was seen, the general adverse effect profile, and how you manage or will manage adverse effects associated with the regimen?
Yeah, so I think the good news was there were no surprises. So what you would have expected for trastuzumab deruxtecan side effect profile is what we have seen as well. We talk about the nausea management, and I think that would still be important, and I think that was something that was definitely seen more so also with this regimen as well up front. We did not obviously see a higher rate of ILD given that we're giving only 4 cycles, which was, I think, very nice to look at in terms of what distinction it had. Very reassuring that we don't have deaths. This is early stage setting. We definitely don't want therapies that can lead to fatal outcomes, which is a good thing to see here. And from an anthracycline taxane-based regimen, again, the expected side effect profile is what we were able to see. But I think overall, all the toxicities that we saw looked better. We have updated data for safety at this meeting as well. To talk about Destiny Breast 11 safety. And again, as I said, I think looking at a regimen that we rely on for our very high-risk patients, which is an anthracycline taxane-based regimen, and having an option which looked better, safer from a toxicity perspective, I thought was very reassuring for our patients in clinic.
Absolutely, couldn't agree more. And let's talk a little bit about that control arm, because there has been some discussion about an anthracycline-based regimen, and certainly, you and I both grew up and trained at the same place, and we certainly use anthracycline-based regimen. This is high-risk disease, after all.
Yes.
So I will say that I personally think that this is the appropriate regimen for the control arm. But what are your thoughts about the control arm in terms of the study design?
Absolutely. We belong to Northeast together. I still belong to Northeast. You've moved south a little bit.
That's right.
But we're not on the West Coast. So I think we still have some belief,
yes,
I think, in the anthracycline-based regimen. And I think I completely agree with you. I think, we used to think that anthracycline was the only way to go. And then we have non-anthracycline regimens like docetaxel carboplatin and dual HER2 blockade that we utilize. I think we have adapted that into our practice with data that has shown non-inferiority approaches for those regimens. But I still use anthracycline-based regimens for our highest risk patient population. And yes, you can have slightly more cardiotoxicity or a secondary leukemia. Thankfully, those rates are lower, but they still are present, and we discuss that with our patients. But, it's not that a non-anthracycline docetaxel-based regimen is actually much easier or a walk in the park. I mean, they have their own distinct toxicity profiles. And I think we've been able to show non-inferiority. There's no data set that tells me that using docetaxel carboplatin HP is superior than anthracycline taxane-based regimen. So in my mind, I think this control arm is still very appropriate. I am not necessarily discouraged by the fact that this was not. I'm not necessarily convinced that if it was a non-anthracycline-based regimen, maybe the safety profile of T-DXd and THP would have looked worse. So I'm not necessarily bothered by that. I think this was appropriate. I still use it. I have adapted PCHP in my practice. I would use that too. And Destiny Breast 05 allowed both, for the right reasons, because we are using both kinds of regimens for a right patient. It's just that we're using more of TCHP than we did before. So I think it is a very appropriate regimen from that regard. And I think my impression of the data does not get impacted by the control arm.
Absolutely, couldn't agree more. And I think, when we see such a dramatic delta difference between the two arms, it's hard to imagine that a different control arm would produce much of a different conclusion. So thank you for walking us through that.